freshman. So we're going to talk about acute kidney injury. We're going to talk about chronic kidney disease, chronic renal failure. So there's some words that I'm going to be throwing around. And we're going to talk about some treatment modalities such as hemodialysis, peritoneal dialysis, or CVVHD. Have you guys seen any of that on the ICUs yet? Love that stuff. That used to be my jam. So I would be like, I'd punch people to get that CVVHD. So we'll talk about that and how that kind of comes into play. So we've changed our language from acute renal failure to acute kidney injury. And I'm sure you've all been in the ICU, right? I'm sure you've seen AKI. Am I right? Somewhere on one of your patients, right? And you go, oh my God, this is like very frequent. And it is. Critical care, that's a big, big connection. A lot of acute kidney injury based on things that happen to the patient. So you're going to see that. So we're going to talk about it. But the thing with acute kidney injury, I want you to understand it's reversible. Let me say that one more time. It's reversible. Now, I certainly am not going to ask you a test question. Is acute kidney injury reversible or not reversible? But I need you to understand when you're caring for these patients, you can turn them around. Okay, if you get to it soon enough. So we'll talk about that. All right.
I think that's a good test question.
No, not in the least. All right, why isn't it clicking? Okay, so you can take a look at the class objectives, but what I want you to remember, this is going to be injury. There are three phases or three types of acute kidney injury that I will break down very succinctly for you. Okay, and they're very different. So we treat the patient very differently if it's pre, intra, or post. And you're like, I have no idea what that means, but I'm going to tell you as we go along. So the concepts here definitely is elimination. So we have an alteration in that elimination. But we must think about the acid-base balance, fluid electrolyte, and see how this sort of built the case from Jill teaching fluid electrolytes, and now we're talking about kidney. And then immunity, because their immune systems are a lot of whack and they're high risk for infection. And then perfusion. Depending on the type of acute kidney injury, could be because of decreased perfusion to the kidney. So it's definitely an important thing to pay attention to. So those are all concepts that we're going to talk about. All right, so acute kidney injury, its onset is quickly. So I come into the emergency room and you get my blood pressure and it's low. My mean arterial pressure is below 70, right? Remember we talked about that 70 to 90 for the and I present to the emergency room with normal BUN and creatinine. And you don't fix my blood pressure, okay? You don't fix my blood pressure. And then we draw some blood work 12 hours later, 14 hours later, a day later, and there's a change in my BUN and creatinine, okay? So that's why when we started teaching you about lab work, we wanted you to really look at the baseline so you knew where that patient started. Does everybody come into the emergency room with a normal creatinine? No, but you need to know what their baseline is. That's crucial. Because then we know, if you come in and say, well, their creatinine's 7, probably on dialysis. Everybody with me on that? So you got to really pay attention to what that patient's baseline is. Longer you're in the critical care unit, the higher the risk. And I can't tell you, I think the last time I was on call, I think we had 9 patients in the ICU, all acute kidney injury with COVID, all acute kidney injury. Somebody with some low sodium or whatever, but they all ended up with acute kidney injury because of certain things, and we'll explain what happened. But the longer I am, the higher the risk. So we got to treat it early. You have to be warriors looking for this. And when I was getting my master's, I went with one of the doctors I actually work with now. And I said, well, what's the problem? He goes, you guys call me too late. So they wait for that creatinine to keep going up, keep going up, keep going up, and it's too late. So you want to make sure that you notice those trends. What is a normal creatinine? 0.7. So 1.2 at Mercy. Now, you might go down the street and it might be 0.6 to 1. Look at your reference range, but every nurse in the world knows that a creatinine of 1.5 is elevated. Everybody got that? At any rate, I don't care where you're going. So a creatinine of 1.5 is elevated. What's a normal BUN? 6 to 23. Again, everybody in the world knows a BUN of 30 is elevated. Everybody got that? So you got to know the baseline or the normals to know when it's an abnormal. Frequent causes. So Jill's going to talk to you guys in a couple of weeks about septic shock. And that's a big cause of acute kidney injury. And then hypovolemia. So that 90-year-old patient who's been vomiting and having diarrhea, volume depleted. There's nothing circulating to get to the kidneys. Or volume depleted, okay? For whatever cause of hypovolemia. Vomiting, diarrhea, not drinking, whatever. Drug or medication related. Anybody think of some really bad drugs for the kidneys? Say it again. It's not necessarily bad for the kidneys, but when you add dye, it can cause lactic acidosis. So we'll talk about that. Like, so vancomycin, nephrotoxic, guys. The aminoglycosides. You're going to have an antibiotic lecture coming up. The aminoglycosides are a big problem. Gentamicin, tobramycin, neomycin. Those are big, big, big ototoxic and nephrotoxic. Okay, vancomycin is another big culprit as well. Cardiogenic shock, very different than septic shock. You'll learn the differences. And then multi-system dysfunction. And Jill's going to talk to you guys about MODS, or multi-organ dysfunction. And the more organs we add, the more complicated things get. So if I have one system failure, I might do okay if I have respiratory failure. But now I'm adding my kidneys, now I'm adding the heart. And the more that we add, the more complicated things get. Make sense? So you might see something called MODS, multi-organ dysfunction syndrome. So, and this is not a test question, so let me just be clear on that. But I want you to understand how they get into the way that they look at where you're at with regard to dysfunction. So we call it the Rifle criteria. And so the risk, you might see an elevation in the creatinine. Please don't write this down. This is just to get reference, 0.3 over creatinine. So let's say my creatinine was 0.6 when I came into the hospital, right? And now it's 0.9. You see the 0.3 increase? So I got to start thinking, even though 0.9 is normal, isn't it? What's going on here and why did her creatinine go up? So that's the risk. And we've got to identify those patients. You all just said vancomycin, aminoglycosides, contrast dyes. You got to identify that patient that's at risk and be vigilant of like, hey, pay attention to what's going on with this patient. Injury, 2 times the normal. So if I normally have a creatinine of 1, it's up to 2. Now you might say, well, 2 doesn't sound that big of a deal. It is. It's a small reference range, so any change in the creatinine is significant. Do you guys get that? Now, if it goes by 0.1, who cares? But if I'm 1 and now I'm 2, you better have alarms going off in your head. Failure is 3 times. So I was 1 when I came in, and now it's 3. You guys see that? Doesn't seem significant, but it is. And then losses. This has been going on for about 4 weeks. You guys see that? It's not recovered. We're not recovered. So it's going on for about 4 weeks. And then end-stage kidney disease, GFR about 15. Glomerular filtration rate of about 15 or lower. And no recovery going on. Probably on some sort of renal replacement therapy. Think about that? Now, the other criteria that's below, have you read in the charts, AKI, stage 1, AKI, stage 2, AKI, stage 3. So, of course, the higher the stage, the more severe the acute kidney injury is. And for reference range, if you see somebody that's AKI, stage 3, you're like, oh boy, way more serious than somebody at stage 1. Of course, stage 1's not good either, right? Because I don't want kidney injury, period. So you'll see them, and it's based on the change in the creatinine. I'm not going to have you memorize that. It's based on the change in the creatinine. So that you'll see them document, the nephrologist, AKI, stage 2, stage 3. That's reference range for you to understand. Oh boy, stage 3, very, very serious. Okay, and we'll talk a little bit more about the types of AKI in a minute. So who's at risk? If I have a baseline of creatinine of 1.5, living at home, I have no idea probably that I have dysfunction, right? Pretty silent. Then I get sick. Don't you think I'd be more at risk than somebody who has normal BUN creatinine? So that's what that's talking about. Did you read in your charts AKI on CKD? So here's what I need you to understand about that chronic kidney disease. Never am I going to be better than 1.5 if that is my baseline. You guys get that? I already had chronic kidney changes. I'm never going to be normal. I'm just going back to the baseline. I don't want to be 2. I want to go back to 1.5. Everybody got that? So that's what that acute on chronic means. I have some underlying chronic kidney disease. Maybe I've been a diabetic for 30 years. Slight elevate. My dad's creatinine's been hanging around 2.9 for several years. And then he got really, really sick. And then his creatinine shot up to 4. We got it back to 2.9. That's all the best we ever got him back. Do you guys see that? I can't get him normal, ever. Been diabetic for 30 years. He's got chronic kidney changes. Older age and acute kidney injury. One is they don't drink as much as we do. They get more dehydrated readily. And our nephrons aren't as functioning as much. So we do have a decline in those functioning nephrons. So older age, definitely a risk. Heart failure and acute kidney injury. I cannot tell you how many patients I have taken care of that have a history of CHF, heart failure, and kidney disease. Anybody know why?
You can't perfuse.
Say it again.
You can't perfuse the kidneys.
Why not?
Because
You know the hemodynamics.
all backing up work.
No. Well,
Cardiac output.
decreased cardiac output first. So I've got this heart that doesn't pump effectively. It's not getting it out. And you're right, it does back up. Everybody that said that, it does back up. But initially, I'm not getting that cardiac output to the kidneys, right? Boom. I see that together all the time. You guys understand? I see that together all the time. Respiratory failure. Jill talked about this. Might even have been a test question. Positive pressure ventilation because it decreases venous return. Therefore, I have a decreased cardiac output, right? Sepsis. When I have massive vasodilatation and sepsis, again, it's about perfusion. I decrease perfusion as well. We're going to talk a little bit more later about rhabdo because that's one of my favorite things to treat. And trauma admissions. Why would they be at risk? You could be for hypovolemia, for trauma who bled out. Give me some. Why?
All of your like intercellular cells, like electrolytes in your cells are now outside.
Why?
The trash.
Because of what? So when you think of crush or trauma and any kind of injury, somebody just punches me. I could have injury here, right? I don't think I'll go into rhabdo, but you have those intracellular things leaking out. What's inside my cell? Potassium. So your brain says, oh, I'm probably going to see a high potassium with this. Because all of that, those cells are ruptured from the trauma. Rhabdo, we'll talk about in detail a little bit later, but that's when the CK gets released from a muscle that's breaking down. Let's say I decide to run a 100-mile marathon. Never will I do that, but let's just say I choose to train for that. And I've excessively exercised. And my muscles will break down, won't they? Rhabdo. Patients that are seizing that we can't get them to stop, that muscle will break down. I've actually had seizure patients who've gone into rhabdo. Okay. So we'll talk a little bit more about rhabdo as we get to it a little bit further in the handout. So you guys talked a little bit about this. And, you know, this is such a culprit. Let's imagine that I've got this underlying kidney disease, slight elevation in my creatinine, and you decide I need a CAT scan, because doesn't everybody get a CAT scan in a year? Everybody under God's green earth gets some sort of CAT scan. Okay? Now, if I add that contrast, now I've really complicated it. So you'll see them documented as CIN or contrast induced. So the way to prevent this is, for God's sakes, take a look at your patient's BUN and creatinine before they go down for a CAT scan with dye. They usually ask us to. And then my dad, with the underlying kidney disease, he had to hydrate. And they're talking liters of fluid to drink if I'm able. So if they knew he was coming in for a CAT scan of his heart, they said, you got to drink a bunch of fluid because we want to flush that out. So that's the best ways if they can. Now, if they can't drink because they're unresponsive and on a vent, we're going to hydrate them with fluids. Does that make sense? IV fluids. The other thing is you might run a bicarb drip. I don't see them ordering bicarb drips that often anymore. Sometimes it can make the acidosis worse. So I don't really see that as much. The other thing, what they did with my dad was they made him take Mucomyst before his CAT scan was done. And Mucomyst, or the acetylcysteine for the overdose for Tylenol, dilates the renal arteries and helps perfusion to the arteries. Your book's going to tell you not as effective as they think it is, but that's what they made him do, is drink Mucomyst. It smells like rotten eggs.
Jesus.
Oh, we're
Holy
going to die.
shit.
So, no one. So, this is why we wanted to be downstairs. I was sitting there watching them this morning. Now, we in the ICU love catheters. Why?
Monitor
I
IVF
know.
strictly.
Strict, right? I mean, and I might be lazy and don't want to have to keep changing something, but it really tells me how well my treatments or whatever I'm doing, right? But the thing that they, and I can't tell you how many people have come and didn't have a UTI and we gave it to them by putting Foley. So a couple of things, they're like, and don't ever put a Foley catheter in somebody who's on dialysis and makes no urine. I can't tell you how much that drives me nuts. I'm like, why do we have this catheter that they're in Europe? They don't make any urine. Why would you put a catheter in somebody who doesn't make any urine? So be very cautious, be very careful, use sterile technique, get them out as soon as possible. So that's what those CUSE and safety things are, is we're really trying to pay close attention to not just putting catheters in because, and we did that in the ICU. As soon as the patient came there responsive, we didn't even ask if they were a dialysis patient or not. We shoved the catheter in them. We just did that. So please be very cautious about that. Hemodynamic monitoring, it's crucial that you pay attention to how well they're perfusing. So if you see the mean arterial pressure drop, please contact somebody. Don't wait. Or you're like, oh, I only got 10 of urine, I'll wait next hour to see what it does. You see the urine output drop, you need to contact them. But the mean arterial pressure is like one of the first things that you'll see. And then the urine output drops and it all kind of goes together. Daily weight, maybe they're up 5 kilos. Very important that these patients, every critical care patient, is weighed daily. I don't care who they are. Weighed daily. They're acutely ill. We need to know where they're at fluid-wise. Okay. And then, could I have fluid not in the right space? So I could have massive amounts of edema, right? But be intravascularly depleted. But I'm swollen. Everybody got that? It's not in my vessel, it's leaked out. So I look intravascularly dehydrated and fluid overload in the interstitial. Yes?
So that's why the opposite of this is intravascular.
But that's extracellular fluid. I'm not talking about intravascular. So cross out the extracellular fluid. Intravascular overload is just purely within the vessel. I'm in heart failure. I have excessive amount of volume. Okay. Now, so cross out the extracellular. We don't care about what the cells do. It's just saying that the fluid leaks out of the cell and goes into the intravascular space. And we can have hypertension and all those things. But let's just back up a minute. if I'm intravascularly depleted and interstitially overloaded. That means I have third space. Everybody got that? So it's really important that you pay attention to what the patient looks like. Now, can I be intravascularly depleted and not interstitially? Right? Sunken eyes, all those things that look like volume depletion. Make sense? The edema comes when the fluid leaks from the intravascular space into the interstitial. Now, I can be in fluid overload, not have edema too, right? My blood pressure might be 200 over, but I'm not leaking out into the interstitial space. That makes sense? Yes? No? You good, Kara? Sure?
Then we do need to change it on our slides, so that's back.
I said cross it off. Yeah, cross that off. But here's what I want you to, what you say with the clinical assessment. Pay attention to what I'm saying. Really depends on what the patient looks like. If I go in and I hear crackles, and that's not a question that you have to use your assessment for this. If I have crackles and I have edema and I have an S3 and I have ascites, what are you thinking? Fluid overload. And if I have ascites and edema, it's in the interstitial, isn't it? So you got to pay attention to what your assessment findings are. I'll go in and a patient won't look fluid overload at all, but I get a chest x-ray and they're on heart failure. Do you guys see that? They don't have the edema because they probably have a normal amount of protein to keep it in the vascular space. So you really got to pay attention to the whole picture. Does that help? Cross it off if that doesn't make sense to you. Pay attention to, and I'll get into each types of acute kidney injury in greater detail. All right, absolutely 100% need to know these types. Now, not going to be, yes, this is you've got to figure out. So let's talk about each one of these. Prolonged hypotension. Sepsis or massive vasodilatation. If I had an allergic reaction, I had massive vasodilatation. Okay. The issue is, if my blood pressure is low for a very long time, it's going to transition. Do you see down there? And it's going to make the kidney ischemic because I've had prolonged hypotension. I may start as prerenal, but if I don't fix it, I'm going to transition into intra. Make sense? Okay. Decreased cardiac output because I'm not perfusing. So heart failure, cardiogenic shock, prolonged volume depletion, dehydration or hemorrhage, and then renal vascular thrombosis. So we have two renal arteries, right? It's got to occlude both because if one's just occluded, the other kidney is going to function. So it's got to be bilateral. Maybe a big tumor before it bifurcates, but it's got to be both because my other kidney will function. We could live on one kidney, right? Yeah, there we go. Intrarenal, more serious. So pre-renal, you think, what do you think with pre-renal? It means anything before the kidney. What do you think you need to do? Your brain says what? Okay. What do you think your treatment's going to be? Fixing perfusion. So whatever that means, does that mean make my heart contract better? We have to increase the perfusion to the kidneys. Whether it means I'm severely dehydrated and I need volume. Whether it means I got this bad heart that doesn't contract and I need a positive inotrope to contract. Everybody got that? So you're right. Treat the cause. But we're trying to fix the perfusion to the kidneys. It occurs before the kidneys. The problem. That's why it's called pre-renal. Intrarenal is you give me a narcotic, you walk away and leave me all night to be hypotensive because I've never had narcotics. And my mean arterial pressure is 50 all night, 8 hours. There's your prolonged kidney ischemia. You guys see that? Because the kidney hasn't been getting blood, hasn't been getting blood. So that's ischemic. And then have you read in the chart ATN? Acute tubular necrosis. That's what we're talking about. Toxins, rhabdo. So we release myoglobin and we release creatine kinase, or CK, And that's very toxic to the kidney. Okay, myoglobin in particular. Tumor lysis syndrome, if you have a medication that actually, is that talk transplant yet? Okay, she will. She can talk about that. So there's a medication that can cause tumor lysis syndrome. Never have I in my 32 years taken care of anybody with tumor lysis syndrome. And then infection, acute glomerular nephritis. Acute, because now we're damaging the glomeruli. Now we're damaging the glomeruli within the kidney. So it's actual damage to the kidney tissue. Everybody got that?
So you don't have to go from renal to renal, you can just jump into renal and not.
Sure, 100%. She said, I don't have to go through from pre-renal to intra. I could just, if you give me vancomycin and never check my blood levels, you directly have damaged my kidneys. I'm intrarenal. So one of the jobs of the nephrologist is to decide whether it's pre-renal or intrarenal. We do some tests to figure out which one it is. So yes. Now, if we don't treat that pre-renal, can it transition into intra? Yes. That prolonged ischemia. Yep. And then post-renal, if we had to pick any, let's pick that. Because that is just fixed by, maybe I have a bladder tumor that's obstructing urine flow. Maybe I have bilateral stones. Remember, it's got to occur on both sides. Because if I have a big stone that's obstructing my right kidney, left kidney is going to do its thing. You got that? So it's got to be bilateral. Maybe an enlarged prostate, can't urinate past that. We go to surgery and we fix that. Very rarely seen. These two are what you're going to see in the ICU. Pre and intra. All right. This is from your book. I'm a visual kind of person, but so we need to know the baseline. That's why you need to go back to admission, you guys. That's why you need to really look at. And then you notice that they had an episode of a drop in blood pressure. If you're lucky and have hemodynamic monitoring, you see the cardiac output drop, but not always. We have all that hemodynamic monitoring. Now, I'm smart enough to know that if my patient's been on vancomycin, my brain says I better check levels because I know how nephrotoxic it is, or gentamicin, or any one of those aminoglycosides. And then that ongoing hypoperfusion is, you didn't fix my heart failure. You didn't fix my low blood pressure. I've been for 12 hours with a low blood pressure. Do you guys see that? Chronic, ongoing ongoing hypoperfusion. You don't fix my mean arterial pressure and get my blood pressure up, I'm not going to perfuse the kidney. Okay. So what do we see? We see an elevation in the creatinine BUN and a decrease in the GFR. What's a normal GFR? No. What is it? I hate that greater than 60. A normal GFR is about 125 milliliters a minute. So why do we say greater than 60?
It can still perfuse functionally if it's greater than 60.
So here's the thing. Myth to that. About 50% of your nephrons, if you're less than 60, are damaged. So if you come in at a 59, you already have 50%. Because 60, half of 125, 60, 50% of those nephrons. Yeah. Can I still walk around Walmart and be asymptomatic? Yes.
So why do they say 60?
Because I don't know. It drives me absolutely bonkers. Now, in the nephrology world, we actually get the actual GFR. So because a GFR of 90, now we're into stage 1 of chronic kidney disease. You wouldn't even know it. You wouldn't even know because it says greater than 60. A GFR of 66, stage 2. You don't even know it. By the time you get to a GFR of 59, now you're at stage 3 kidney disease. See why I don't like that GFR?
So what comes first, the GFR issue or the human creatinine?
It all really depends. Everything's just as important. The GFR is definitely way more specific, you guys. Way more specific to kidney function. Say it again.
Is there a range for the GFR or just 125 is the best and then it goes down?
125 is what is anticipated. 120, it depends on if you're male or female. But as we get into 90, if you say, hey, my GFR is 90, I'm already stage 1. And when we get to chronic kidney disease, I'll talk about those stages.
So if it's 125 and on the lab, or how how does the nurse know? Because it
We
just
don't.
indicates-
We don't, that's my whole point. So now I start vancomycin on somebody whose GFR might be 61. And now I just knock them right into acute kidney injury. Do you guys see why I don't like that GFR? That's exactly why I don't like it.
Why is there a difference between like African American and just?
Yeah. it's-
Not, well, you jumping ahead now.
Oh, okay.
But with African American, we look at the creatinine because there's more muscle mass with the African American population. They have a higher muscle mass than the Caucasian, so they can tolerate higher creatinine levels. So two people in a bed. A bed has creatinine of 1.2, B bed has creatinine 1.2. African Americans, GFR is normal. Caucasians might be off. So there is a difference. That's why you need to know the rates of your patient. There is a difference. So I've seen higher creatinine levels tolerated better in the African American population. Yep. So that's why you need to know. Okay, so not everybody in acute kidney injury has a decrease in urine output. Just so you know that. It could be making urine, but it could be empty urine. So they're not clearing the waste. And the only way that I would know that is if creatinine is still going up, but they're making urine. Does that make sense? More often than not, I see in the ICU a drop in the urine. The other thing is you're going to start seeing them gain weight. I had a patient 100 pounds over what her normal weight was due to all the food I did. She was in the ICU for 3 months. So you really want to pay attention to those daily weights, okay? Yes.
So like, we had a cardiac arrest and they were a dialysis patient.
Mhm.
They said that he didn't make urine and when we went to CAT scan, it showed that his bladder was full. We ended up coming back to the catheter and we got like 1750 out.
No kidding.
So like, would that be a case where like he essentially makes urine, but it just isn't actually coming out?
It could definitely be that. So what you're talking about, when we say somebody's anuric, that's about 50 mLs a day or less. Oliguric is about 400 milliliters a day or less. He could have been somebody who just didn't, whether he had an enlarged prostate or what the issue was, it could have collected. Then he probably had a UTI, I'm gonna imagine, because that urine is sitting in there. So it's possible. Bladder scan, but you wouldn't automatically think, oh my gosh, we need to. Now the patients more often than not tell me, I still make urine. And I'm like, okay. So you got to find that out in their history.
So what about the hypertension thing? If you have somebody in hypertensive crisis?
Hypertension is the biggest.
You're active on chronic under diagnosis.
So hypertension, chronic kidney disease, that's the one of the number one causes, diabetes and hypertension. Because hypertension is like taking a bat and just beating the crap out of your kidneys. And it's this constant pressure that is up. So the hypertension will cause chronic kidney changes. The acute is, let's say I normally run a high blood pressure, now I drop the pressure or whatever. it is. Now, management is going to be different. And you say, well, that seems opposite, diuretics and fluid restriction or whatever. It depends on the cause. Let me say that one more time. When we get into each individual cause, we'll talk about it. If it's pre-renal or volume depleted because I've been puking and pooping, we're going to get back volume and not a diuretic, right? Because I'm down. My pool is empty. If it's heart failure and I'm edematous and my weight's up 10 kilos, diuretics make sense, right? So you really got to base it on what your past medical history is and what your clinical findings are. Okay. So, and then we'll talk about on Thursday, renal replacement therapy, the different types of dialysis. More often than not, what you see in the hospital, if you're seeing CVVH, it's probably CVVHDF, that bottom one. And that means continuous veno. So in the vein, not in the artery, hemodialysis with filtration. Okay. So we'll talk about that when we get a little bit further along. The beauty is if we catch this early, the kidney recovers. You start seeing the creatinine come back to the baseline. You start seeing the patient sort of stabilize. If not, and they don't recover, then they're gonna be a hemodialysis patient or peritoneal or, no, probably hemodialysis. And then death, which is the most unfortunate thing, but it could. Okay, so I want you to read this question. What's the key word in this question? Before. Yep, so highlight that before, circle it, whatever. So what type of kidney injury is it? Yes. All right. So let's start from the beginning, the assessment. One of the things that we ask is how often do you go? Are you going in the middle of the night? Do you notice a change in the color or amount of urine? Do you have problems starting the flow? Do you have problems with dribbling? All of those things. Any recent surgery or trauma, because I could have dropped my blood pressure, right? I dropped my blood pressure. Drug history, and that doesn't necessarily mean illicit drugs, but my mother loves NSAIDs. She pops Advil like it's their M&Ms. And I'm like, Jane, I'm gonna have to drive you to dialysis. So we really do ask about NSAID use and different medications. Maybe I was on an antibiotic or something. So really asking that question of what medications do you take? Any coexisting conditions such as heart failure, diabetes, anything that, history of hypertension, all gonna play a part here. Any acute illnesses such as COVID, that whole inflammatory response, sepsis, and then anticipate after hypotension or shock. Your brain says if they come in for ER and they're hypotensive, your brain should already say, I'm sure these kidney function is going to be decreased later. Somebody cardiac arrest for you, I'm sure their kidney function is going to be decreased later. Not going to show it right then and there. Cardiac arresting them, it hasn't had time for that numbers to change, but 6 hours later you get a creatinine and it's elevated. Anticipate, prevent, okay? Hence why we run fluids wide open during teams. Give them fluid to help perfuse the kidneys, okay? So hourly output. Please do not wait and go, I'll wait a couple hours and then call. You see a drop, you give them a call, okay? Assess for fluid overload. So daily weights, neck vein extension, S3. You get a daily chest x-ray, don't you, in the ICU? Most patients, most. Take a look at the chest x-ray. That's sometimes the only thing that who I work for, will order diuretics because the chest x-ray looks worse today. So pay attention to the chest x-ray as well. And then vital signs. If they say, oh, the pressure's been 70/40 all night, what are we doing? What medication could I give to increase the mean arterial pressure? Norepi. What else? That's Norepi. Epi, which could increase my heart rate, so we got to be very careful with the heart rate. Say it again. Dobutamine is going to help with contractility. It's not going to help with my mean arterial pressure. Say it again. Neosynephrine. Vasopressin? No? Yes? Okay. Dopamine, if you're at St. Joe's, I guess St. Joe's uses dopamine. I haven't really used dopamine in years. So again, paying attention to that mean arterial pressure and those hourly outputs and your physical assessment is crucial. All right, so this is a little bit involved. I can't find a better picture, so just bear with me, but I really like it because it really, and it's the same for chronic kidney disease too, so you don't have to learn it. That's the nice thing about chronic, same symptoms and all that stuff. But I want you to look at, do you see a system there that's not affected by kidney failure? So if you look here, let's start to the left. That hyperparathyroid. And what happens, and it's not usually in the acute, but I see it more so in the chronic, the parathyroid goes into overdrive to sort of regulate those calcium and phosphorus levels. So these patients might have a secondary hyperparathyroidism. Okay. And then I haven't seen so much the glucose intolerance, but you know, we're going to monitor blood sugars. Pulmonary edema, pleuritis. Normally, we don't wait so long for them to get pleuritis, but pleuritis is that, what sound would I hear in my lungs? Pleural friction rub. Because of the high toxin levels of feline creatinine. We don't wait that long anymore to get to that point of pleuritis. Of course, if you're at home and you wait and then maybe they will. Pulmonary edema, of course, because I'm not making urine and I have fluid volume access, pink frothy sputum, like Kussmaul's. We're severely metabolically acidotic, right? Please do not sedate them and stop their 40 times a minute breathing. They're trying to compensate. They're trying to compensate. Okay, urinary, proteinuria. So your urine analysis, if you're not writing down your patient's urine analysis, you're missing a big, that's a great tool to tell us what's going on. So am I dumping protein? Because we shouldn't be dumping protein. It's a large molecule. And they base chronic kidney disease based on the amount of protein you dump out. So that's a very important thing to look for. I shouldn't spill out red blood cells either, hematuria. They're a big molecule, I guess, and you should not be spilling out red blood cells. A fixed specific gravity. So tell me what a normal specific gravity is.
1.0.
So dimes, we used to call it dimes to quarters, but they changed it to 1.030. In kidney injury, kidney failure, and particularly more of the chronic side, 1.010. It'll, no matter what time you get their urine, it will always, it can't concentrate or dilute that urine. It's fixed. Does that make sense? So when we get that specific gravity, I don't care what time you get it, it's always got to be 1.010 or fixed. It's not going to move.
Always.
Say it again.
So weird.
Always. Yep. Fixed. Nocturia patient might say, oh, I've been getting up and peeing at night more. Okay. And then oliguria and anuria. So what I'm saying about oliguria is 400 milliliters or less a day. That's oliguria. Skin. Anuria is about 50 milliliters of urine a day. And I'm sure those of you work in healthcare, you put somebody on a bed pan and they pee like 5 milliliters. And you're like, seriously, you know, but that's that anuric patient. Gastrointestinal, they'll be anorexic, they'll have nausea and vomiting, they might have some inflammation, gastroenteritis. Uremic fetor, that one down there is, and the books say it smells urinous breath. Honestly, I've never gotten close enough to say your breath smells like urine, but it's a characteristic smell. So uremic fetor means that this breath smells like urine. My patients are intubated and mouth care every 2 hours. They're at high risk for GI bleeding. Platelets are usually kind of wanky, and they're at risk for peptic ulcer. Osteodystrophy, not probably going to see that in acute, more in chronic. That is renal bone disease due to the calcium, and phosphorus imbalance. Okay. And if I have calcium leaking from my bones, the patient complains of bone pain. Renal osteodystrophy. All they do is put renal in front of that osteodystrophy. Yeah. And then
Thyroid, or there's not any sense in it, but it's a parathyroid causing a secondary.
well, the parathyroid kicks in overdrive once I'm in kidney failure. So the kidney failure causes that parathyroid to go into overdrive. So calcium leaks from the bones, you guys. So now I'm at risk for spontaneous fracture. Patient will say, I was washing dishes at the sink and I fell. And then I broke my hip. Well, they probably broke their hip and then fell. Does that make sense? That's what a spontaneous fracture is. There's no injury induced, it just fractures. Okay. decreased leukocyte count. So you can see these patients are at increased risk for infection. Don't care. Don't argue with me. That's the number one cause of death in these patients is infection. Okay. Neuro, I haven't really seen that a lot because again, we dialyze much sooner than we used to years ago. I've not seen people, and the only thing I think with seizures is if my sodium level is so low because I'm so diluted out. Everybody got that? If my sodium level is so low, I'm so diluted out, fluid overload, that my sodium is 119. I could have a seizure. If I am not making any urine or anything like that, I can be hypertensive or I could be hypo. So I want you to put both. It could be either or. Okay. If I'm in fluid volume excess and heart failure, I might be hypertensive. If I am septic, I could be hypotensive. Do you guys see that? So again, you got to know what the cause is. And then coronary artery disease, dysrhythmias. Anybody know why the dysrhythmias?
Because of the calcium?
Nope. Well, it could. Well, if it's low enough, yes.
Okay.
Yes. No.
Well, weren't we
Potassium.
just talking about the potassium coming
Yes.
out of this? Okay.
Yes. Potassium. I'm not urinating, so I'm not excreting potassium.
Bless you.
All right. Oh, wait, let me go back. Let me see what else we need to talk. Heart failure, yes. Anemia. They are chronically anemic. Please do not lose sleep over a hemoglobin of 10 and a hematocrit of 30. We're jumping for joy in a renal patient, okay? They're never going to have normal or chronic especially. Impaired clotting. So you want to check and see, are they bruising very easily or platelet count low? If they're young enough, we can have problems with periods or impotence. The skin here, I want to talk a little bit about that. This uremic frost. I always got to bring it up. Never seen it on a patient, but I'm going to tell you that. It has to do with the calcium phosphorus alterations, and it looks like snow crystals on the skin. So frost on the skin. It's due to those imbalances, with calcium and phosphorus. That's called uremic frost. And then I've never saw a patient be yellow-green. They're more pale to me, renal failure. But they talk about uremic skin color being yellowish green. And then this is really important, these metabolic processes. This is where we spend most of our time with kidney failure, looking at the lab. Okay, looking at the lab. So azotemia, you guys, that fancy word, all that means is my BUN's up, my creatinine's up. Azotemia means I have alterations in my BUN and creatinine. I could be walking around Walmart and not know I'm azotemic. Uremic means I'm sick, like I'm symptomatic with that BUN and creatinine elevation. So if you see them say uremic, then we're symptomatic. Azotemia, I could be walking around Walmart, have an elevated BUN, have an elevated creatinine. Hyperkalemia, so the K is going to be high because I cannot excrete. Hypocalcemia. Why is my calcium low in renal? What do I need for my kidney? Whoever just said vitamin D. So if I can't activate that vitamin D, I can't absorb calcium in my gut. So renal failure patients are chronically hypocalcemic. Okay? Renal failure patients are chronically hypocalcemic.
I know that like vitamin D also absorb calcium, but
But I can't make it an active form to help absorb the calcium in the gut.
the kidney makes it enough.
You need the kidney function to help make it into an active form so I can absorb it in the gut. Hyperphosphatemia, I can't excrete high phosphorus. Yeah, but just when you tell me that, you'll come and say both are down or both are up. So more often than not, they have a low calcium and a high phosphorus. Hypermagnesemia, again, cannot excrete it. So they have high magnesium levels. So what drug would I avoid? Any kind, right? Like milk of magnesia, don't be giving them the milk of magnesia. Acidosis, metabolic acidosis. Metabolic acidosis. My bicarb is chronically low in renal failure. And then you can have high lipid levels. It doesn't draw those that often though. And then a high uric acid level, we can't excrete that either. So they'll have a high uric acid level and then malnutrition. Take a look at your protein and albumin on those patients. Okay, so next to that creatinine and BUN, I want to put GFR. So your BUN and creatinine and GFR, one of the first things you're going to get. Not only are you going to get serum electrolytes, you're going to get urine electrolytes. Anybody send that? And they're in the ICU? Yep, urine. Urine electrolytes. Because they can determine, and again, this is not for you guys, but they can determine if the urine sodium is high or low, whether it's pre-renal or intrarenal. That's for the nephrologist, but that's why you're getting those electrolytes. He's trying to determine what type of acute kidney injury that is. Urine test, so UA, one of the first things, right? You can get a specific gravity. Urine osmos, a great test. Why would I get a urine osmo? What do we want to know? Fluid excess or fluid deficit, right? We can tell if they're dehydrated. And same thing with the serum osmo as well. Okay. So specific gravity tells how many particles are in the urine, and specific gravity is in your UA. You have to get a separate test for the urine osmo. Okay. I don't know if there's a big difference between the two, but the UA already throws out the specific gravity. Normally they'll ask for a urine osmo because they can tell which type of kidney injury it is, whether it's pre or intra. Ultrasound of the kidney is one of the first things we do. What are they looking for? Yeah, because if it's an obstruction, don't we alleviate the obstruction, go to surgery and fix it? So we're looking for, an ultrasound of the kidneys, they're looking for hydronephrosis, hydroureter, tumors, right? Stones, all of those fun things that could cause an obstruction. CAT scan, be very cautious with the dye. KUB is kidney, ureter, and bladder. Just a nice x-ray, simple x-ray. This MAG3 is a nuclear test. He doesn't routinely send down for the MAG3 test. I see more often than not the renal ultrasound first. If anything, they're looking also at the renal arteries to see how well the blood's flowing through because we're looking for renal artery stenosis. That will be a nuclear test. Renal artery stenosis. If I have narrowing in those arteries to the kidneys, we can stent those and open those up, can't we? Okay. If we don't know the cause, we can definitely do a kidney biopsy, whether it's like a glomerulonephritis or something else going on. They will, and it's invasive. So it's not the first test that we do, okay? But if we can't figure out the cause, we'll do a kidney biopsy. All right, let's read this question. What do you guys think? And this is how you're going to get questions on boards because they're all crappy, aren't they? Potassium's the most serious, right? So you on a 78, please don't lose sleep over that. That's elevated, but that's not going to kill them. The K of 6.9, that will kill them. Okay. Sodium, if it keeps dropping down, I could have seizures, but 130 is okay. Okay. All right, now I didn't talk about this, but let's see if you can get this, because your book talks about it. And if you read ahead, you'll know this. Yep. So for every kilo that I gain in weight, for every 1 kilo, I gain 1,000, or For every kilo, it's 1,000 milliliters of extra fluid. Does that make sense? So 1 kilo equals 1,000. So if I'm up 2 kilos, you weighed me, I'm up 2,000 milliliters. Make sense? That's why your daily weight is crucial. Because if you come in and they say, oh my God, they're up 15 kilos. I mean, we're 15 liters positive, aren't we? We're going to make a decision with regard to what medications we're going to do. Okay, these are your priority problems. So we're not saying nursing diagnosis anymore. And hypervolemia, again, you've got to assess your patient to tell whether it's in the intravascular space or the interstitial space. Your patient's physical findings are going to support where that fluid is. Okay. And I told you they're at increased risk for infection. I don't know about sleep pattern disturbances. All right. So let's just recap. We talked pre-renal before the kidney. Everybody got that? Intrarenal means within the kidney, some sort of damage to the actual tissue in the kidney. And post-renal, after, right? Now we're going to talk about how we treat all of it. So pre-renal, and I asked you guys earlier, what did you want to do? And you said, I want to treat the cause. And that's 100% right. If my heart is failing, give them an inotrope, right? How would I know the heart's failing? So ejection fraction, if I had an echo, what else? Simple one in ER. BNP, right? They come in, their BNP's over 70,000. You're like, oh my God, heart failure. Everybody got that? Yes, an ejection fraction would be great. Okay, if we had hemodynamic monitoring, it would be cardiac output. So, if it is purely a volume issue, we're going to just dump fluid in. Those of you who got to see traumas in the yard, do they just willy-nilly give them fluid like there's no tomorrow? Everybody gets fluid. They worry about throwing it in heart failure. So everybody gets this aggressive. And what I mean by aggressive, I'm talking liters under pressurized bags, just flying in. Okay. Now, the question is, do we give a colloid versus crystalloid? How do we make that decision? Do we have to make that decision? First of all, no. But we need to anticipate. Who's getting crystalloids and who's getting colloids?
Probably for trauma, and then the crystalloids for like someone who's got diarrhea, vomiting.
Okay, so what she's talking about is that patient who had vomiting and diarrhea didn't lose blood, did they? They just lost volume. So we just need to restore with a crystalloid, like normal saline. Some of our traumas who are gunshot wounds that are bleeding out, weren't we going to do that? Give them back the blood that they're losing. Now, don't get me wrong. If you have a liver failure patient like Jill talked about that has esophageal varices and is losing blood, we're going to give a colloid. You guys see that? So again, knowing their history and what's going on with them. And then you say, well, why am I giving diuretics? And it really, one of the things that, at least the group that I work with, is sometimes they'll do like a Lasix challenge and sort of just hit them to see if their kidneys will sort of wake up and make urine. We'll still aggressively flush the kidneys, but we want to give that Lasix to see if that'll increase the urine output. Now, if I give it and it doesn't really help, we're not going to give any more. Does that make sense? You never have to decide that. That's up for the nephrologist to decide. You just have to anticipate giving it. Prevention is the major factor. So if I'm going to surgery, we know that the surgery causes bleeding. Shouldn't we anticipate that we've got to stop the bleeding, or we've got to not let this patient bleed out? Okay, so definitely closely monitoring vital signs while in surgery. We're going to treat hypotension. We're going to give fluids, low dose dopamine, and we used to call it renal dose, that 2 to 3 mics. The higher you get with that dopamine, the more it messes with the heart. So we don't want a high dose food. Okay. So pre-renal, figure out the cause, restore blood flow to the kidney.
Is that what that's doing?
It causes renal artery dilation, so it'll help. Higher doses will vasoconstrict if you have a really low blood pressure, but it also makes the heart rate go up too, so a little bit cautious about that. Okay, I took a picture to show you, this right here is all dead. You see all those black spots? That's what acute tubular necrosis looks like. It's dead tissue. Remember I said it directly damages the kidney tissue. Most common cause. This is what you'll see more often than not. Please don't memorize that it's 85% of cases, whatever. Two causes of acute tubular necrosis. Post-ischemic, that means that patient that's been hypoperfusing for a very, very long time. That cardiac arrest patient that we seen for an hour, that patient that we gave a narcotic to, that the blood pressure was really, really low, and nephrotoxic. You gave a medication or they overdosed. Can I overdose on NSAIDs? I sure can. Nephrotoxic, and that's also rhabdo mixed in there as well too. But it literally, let me see if the next slide. So the renal tubules actually necrose because they're ischemic. So imagine this tubule and it doesn't get blood flow. So little pieces of that tubule slough off and occlude that tubule. So that's what's happening there. Is because I'm not getting blood flow to that tubule, little chunks of that slough off and occlude with cellular debris in that tubule. So I don't make them. Okay. And here, your MAP falls below 50 to 60. And do you see it's a little bit lower than what I told you guys are normal? Renal's okay with like a MAP of 65. You might ask a cardiothoracic surgeon, you want a little bit higher. Every physician is different. The problem with acute tubular necrosis is high incidence of permanent renal damage. High incidence. So these are the patients that end up becoming dialysis patients in end stage. Who's taking care of anybody with rapid? Anybody?
I had a patient on the floor like 2 semesters ago.
2 semesters ago? What do you remember about it?
Super dark.
Oh, like other. Coca-Cola dark, iced tea dark. Yep. Okay, very good. That's a very strong characteristic. What do you remember?
I remember her, all the, like the open wounds on her legs, like it just. the
Oh, so
muscle-
she was laying in the same spot.
Yep,
Okay.
yeah.
So what she's talking about, and this is probably what I see in the elderly more common, they fall at home and nobody's seen them for days. And they lay in the same spot and that muscle breaks down. And what she's talking about is those wounds. Because I have muscle breakdown, we leak out that myoglobin and see that muscle's broken down because I'm not moving. I'm laying in that same spot. Everybody got that? Now, any kind of insult, a trauma, a car accident, you go through a windshield, you have all that cellular damage. You do anticipate that. Okay, you do anticipate that. So there's your urine. That's exactly right. And some references say red, cola, or iced tea color. Okay, but dark. Because the patient will complain of profound muscle tenderness. So I'll tell the story of a case study that I did. He was an 18-year-old kid who went out partying with his friends, and their wonderful friends dumped him off at home, and he seized all night. Because of whatever, I can't remember what it was. What he took. And he seized all night. His mother found him like, I'll say 10 hours later. And he was seizing when she found him. Bring him into the ER, and he already is in rapid. So you can see the extent of amount of time that, and they tried to put a triple lumen in him, and they caused compartment syndrome. And this whole leg needed a fasciotomy, so they cut his leg open. Now 18, ended up on the vent, ended up on dialysis, and his CK level, 800,000. So let me say it one more time. I've never seen anything higher than this, 800,000. Now, if you have a CK level of 500, No one's losing sleep and thinking you're in rhabdo. It has to be pretty high. Your book talks about at least 5,000 or greater. And the one nephrologist that I don't work with, she said at least 10,000. So you really want to look for those really, really high, we used to call them CPKs, but it's CK, really high CK level. You're going to do a urine for myoglobin. There's going to be blood because that kidney, we're just dumping all kinds of stuff out. K is high because the muscle damage and everything inside the cell is leaking out. Everything inside that cell is leaking out. And then increased phosphorus, BM, creatinine, all those lab values that I talked about. So, and this kid, before he cardiac arrested, meanwhile, his K was 8 something when he came in. He complained of profound muscle tenderness. All right, so how do I treat this? And when I say aggressive fluid, you see that 20 liters in 24 hours? You're running fluids wide open. You are just flushing out. Because that myoglobin's a lot like cement to the kidneys. So you're flushing it out, you're flushing it out, you're aggressively flushing it out. You may even chase it with a loop diuretic like Lasix or Bumax or mannitol. I do see them running a bicarb drip to sort of alkalinize the urine. And this kid ended up on dialysis. Now, I gotta tell you, this kid was in the hospital for 3 months. Dialysis, walked out of here with a normal BUN for that. Cardiac arrested, K of 8, on dialysis, walked out of here after therapy and rehab and all that with a normal BUN. So again, here's a healthy young kid who just had this horrible insult, but they treated him early and turned it around. Okay. So when you hear rhabdo, your brain should already say aggressive fluids. Normally, like saline, is what we use, aggressive, like you're just drowning in the fluids.
Is that like a burn type thing?
It's just a profound muscle weakness, not a burn. I don't know about the pressure ulcer people who have been laying with, but no one's ever referred to it as burning. Okay, aside from rhabdo, what do we do to prevent damage to the actual kidney? Look at their meds. Look at their meds. Definitely, if it's something that has a narrow therapeutic window, you better ask for an antibiotic level. Vancomycin, gentamicin. Also a DIG too, digoxin. Narrow therapeutic window. You really want to make sure you're following the levels. Caution with dye. So you're going to have that conversation. Do you want me to hydrate them before? What do we need to do here? Monitor electrolyte balances. So how often were you guys getting lab work in the ICU? How often were you getting it?
Every 6 hours.
I've got it every half hour. So again, however you, yes, it could be every 6 hours to see where we're at. And then they may start a protein restricted diet as well. Post-renal, simplest to fix. Alleviate whatever is blocking, whether it's a tumor, whether it's bilateral stones. We have to be very careful. You know, I use my father-in-law as an example because he was going in for prostate surgery and hernia surgery and all this stuff. And his belly was so distended. I'm like, is there a tumor in there or anything? So they're getting him ready for surgery. Put a Foley catheter in. He had 4,000 cc's of urine in his bladder. He didn't even know. He had a neurogenic bladder. He didn't even know. He dropped his blood pressure in the OR. He said, it's a good thing I didn't cut into him to fix his hernia because I would have cut into his bladder. It's all the way up there. So you want to really pay attention to that rapid fluid loss after they alleviate that obstruction. Pay close attention to that. You might see them just dump out and they'll drop their blood pressure. Stents if the ureters are bilaterally blocked. Suprapubic if we can't get past the obstruction. We'll put in a suprapubic, or surgery if it's a tumor resection or something along those lines. Okay, collaborative management of patient with any type of AKI. Any type. Infection is a major cause of death. Now, you might say to me, well, Lorraine, I'm really worried about that potassium. Could a high potassium kill them? Yes, but this is the major cause. If you say, you know, what do all these patients from acute kidney injury die from? It's not from the hyperkalemia. We treat that and we see that. It's more from infection, okay? So really pay attention using sterile technique. Okay, getting the catheters out. What is aggressive pulmonary hygiene? Everybody's, wait, coughing and deep breathing, but if I'm on the vent, I can't do that. Go ahead. Suction, what else? What about the bed? Compression? Turn the bed? No? Nobody saw the bed? No? The vest? No? So you could do the vest or you could turn the bed. Our beds in the ICU actually vibrate. Okay? Turning them. Just turning them on their sides will mobilize secretions. Look for their white cell count, fever. Be vigilant about actively looking for infection in any ICU patients that are high risk. Antibiotic dosages require adjustment, especially if you start seeing a change, you know, and the beauty of it in the ICU is we have a PharmD that, you notice that they order the levels and the drugs and things like that? If you haven't noticed that, did you see it?
Is
Yeah.
that why they often do, banking and drug?
And we haven't really done the peaks and troughs anymore. We usually do a random. And again, it's up to the PharmD. They're going to do the dosaging. So pay attention to that. If you have somebody on a medication that's nephrotoxic, you got to be reaching out and saying, where's our level? Okay. Fluid balance, you know that it's hourly outputs. Hemodynamic monitoring, it might be something as simple as putting in a triple lumen and doing a, what can I do out of a triple lumen? CVP, right? And that tells me fluid volume status. Daily weights. Looking for, and I want you to put next to everything, your daily chest x-rays too. You know, most of the patients in the ICU have a daily chest x-ray. If you notice a change in your lung sounds, maybe you need to ask for another chest x-ray. Okay. Depending on where they're at, they could be in a fluid restriction. Everybody in the ICU should be on strict intake and output. You should be monitoring anything that goes in and anything that comes out. I don't care what patient it is, renal or not, okay? Diuretic therapy, if they respond to it. Anybody run a diuretic drip this semester? You make license? Okay, so it depends. It depends. All right, and then renal replacement therapy is dialysis. I think we're going to change that. Okay, so we're going to monitor the electrolyte. This is where we're talking about, and I think you mentioned about every 6 hours. Again, it's individual to the patient. But I just want to caution you that if you are treating something, treating a magnesium, treating a phosphorus, treating a potassium, your brain should say to whoever gave you that order to treat it, when do you want the next level? Because that's the way that you're going to evaluate if your treatment is effective. Don't go, oh, wait till tomorrow. Okay, makes sense? Anything that you're treating. You're hanging blood because the blood count's low. When's the next hemoglobin? When do you want me to get that? We're going to talk about medications for electrolyte imbalances next time. I don't think we'll have time today. But we'll talk about how we treat those. Pruritus is due to those alterations, well, one due to the high uremic levels, creatinine, plus the calcium and phosphorus, and cause a patient to be, you'll see them break open their skin from scratching so much. Okay. And monitor the ABGs because of metabolic acidosis. What lab value would I know without getting a blood test to know their metabolically acidotic? Thank you. You can graduate. All right. We'll do this. What is this? Does it end at 12? When do we end? Oh, you lie. Okay. All right. I'll finish this slide and then we'll stop here. So, high K. Yes, if I'm making urine, the diuretic will make me, the loop diuretic will make me go, right? And helpful, maybe pee out some of that potassium. Thiazide diuretic as well. You can use an osmotic. More often in SIC, have you been done into head injuries? They'll use the mannitol for the head injuries and cerebral edema. So if I've got that and a kidney issue, I might use mannitol to help with cerebral edema. Potassium sparing, you might see them on that if they're a heart failure patient. But again, you may have to hold that med if the potassium is high, right? And then Vaptans is an IV med, and it's used when the sodium's low with excess volume. So we're dilutional. So we're trying to get rid of the excess volume. I haven't hung that Vaporsol. I have not hung that. But you might see it somewhere else. K-Exolate, and then this Localma. What I want you to know about Localma is it's once a day dosaging, not for acute treatment of a high K. So if I have a K of like 5.3, I might take a Localma dose. But if I have a K of 8, do not give me Localma. Not for acute episodes. Not for acute episodes. Okay? I'm gonna probably go to dialysis. Or I'm gonna do what?
Yeah, it must have got cut off. I was looking all over.
I'm gonna, it's in the next slide, but I'm gonna give insulin regular, 50% dextrose and calcium. That is a quick fix for a high K. That's only a bridge to get me to whatever, like dialysis or something like that. Because what happens is that treatment of the insulin and only regular insulin, no other insulin, dextrose and calcium helps that K shift back into the cell, but it wears off, right? Comes back out again if I'm still acidic. So it's just a temporary fix until I can get dialyzed. Okay, so the hemodynamically unstable. And then we'll talk about next time when we get together, phosphate binders. Anybody give any this semester? What'd you give? Foslo? Which one?
I don't remember which one it was. We didn't give it because I rested.
So, well, first of all, Foslo is a tablet. They have to eat it because it has to go with dietary. Hence why it says dietary phosphate binders. I have to be eating. That's what helps. It binds with the dietary phosphorus and I exclude it. Okay. All right, let's stop there. And we'll pick up here. Oh, don't forget to go downstairs and win the stethoscope. You go right ahead.
And how are we gonna know that it's on a true
Thank you for the candy.
You're welcome.
Oh, now